Okay, good morning. How is everyone doing today? So this is going to be a Panopto lecture detailing infections of bone. So we've already kind of talked about this, especially when we're talking about changes in kids with destructive osteolysis. So this is one of the three differentials for aggressive change or aggressive destruction in a younger individual. The three of them are osteomyelitis, which is the infections, osteosarcoma, and Ewing sarcoma. So with that brief reminder, let's get into this. So when we're talking about infections, there's a couple different terms you can use, and it details on where they are. So cellulitis is just an infection of the skin and or subcutaneous tissues, dermal layers and subcutaneous tissues. And that's a pretty straightforward one. This isn't something we're really going to see on X-ray very often. Advanced imaging you could, so like MRI or CT can show it better. The three main ones we're going to visualize on X-ray are osteitis, osteomyelitis, and septic arthritis. Of course, these can be seen on the advanced imaging as well, but this is kind of our first introduction into them, at least on X-ray. So osteitis itself is just infection of the cortex. Osteomyelitis, which is much more common because infection tends to just aggressively destroy the local tissues. Osteomyelitis is infection of both more so the medullary cavity and bone marrow, but we can still use it to talk about infections of the bone marrow as well as the cortex. Like I wouldn't say a patient has osteomyelitis and osteitis. I would just stay with osteomyelitis. The last one that's kind of specific is infection within a joint. So septic arthritis is something that you want to talk about uh, when you see changes around those joints. So the two main ones you'll be using for this class are osteomyelitis and septic arthritis when it's infecting areas outside the spine. And we'll kind of talk more about spine changes as we go on. Again, there's a lot of types when we're talking about going even deeper. So these are subtypes. Acute suppurative osteomyelitis, Brodie's abscess. So this is in the phlegmomachic. That's going to take a long time to write, so I'm just going to dot 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 there. Septic arthritis, chronic and acute osteomyelitis. Those are going to be the ones we kind of talk about with just infection in mind. Diabetic osteomyelitis and septic arthritis. So diabetics tend to be much more susceptible to infection. And the final category, non-suppurative osteomyelitis. So this is more of a tuberculosis or potentially syphilis. And syphilis is a very rare one these days to have tertiary syphilis or the further stages of syphilis. Tuberculosis, though, is making somewhat of a comeback. So that is a potential thing that you might see. For test purposes, for the exam, the practical specifically, you will use these diagnoses. If you're looking to get full credit on any infectious uh, diagnosis for the exam, it has to be one of these three terms. When we talk about osteomyelitis, that tends to imply it is the acute form. If you just say osteomyelitis, that's the acute suppurative, so acute S form. Spondylodiscitis, I mentioned the spine stuff, that's going to be a spine diagnosis. Brodie's abscess, again, this is that phlegmomachic. Septic arthritis, when we're talking about septic arthritis, that's the joint changes. Chronic osteomyelitis is going to have a little bit more of a uh, sclerotic change to it. So instead of just being a lytic change that we tend to see in osteomyelitis, chronic forms of infection have much more overlying bone laid down. And then TB spondylodiscitis is a little bit different from the regular spondylodiscitis, and we'll talk about that. All right. When we look at the way that infection spreads, much like neoplastic disease or cancer, hematogenous is the much more common route. Infection can also spread from say, a cellulitis into the deeper tissues and go into bone in that sense, so it can directly extend from an area. There can be implantation, so you get into a bar fight, you punch someone in the mouth, and their teeth cut your skin. That is a direct implantation of bacteria from the mouth onto say, your knuckles, which is a common cause of a septic arthritis in the metacarpophalangeal joints. And there's also a post-operative one. When we see surgeries are as sterile as possible, but it is very, very difficult to completely eliminate all sources of bacteria because humans are involved in the surgery. And once there's a human in it, obviously there can be areas of infection. Okay, so who's predisposed? Here's a quick list of people who are predisposed. Generally, it's going to be someone that is immunocompromised. So alcoholics tend to have a little bit more susceptibility to infection. Same thing with newborns, older individuals, IV drug users, just the needles themselves. If there are some shared needles, those can also be a source of infection. Diabetics are immunocompromised. Same thing with those undergoing hemodialysis as well as post-surgery. So a real easy test question to write is, what is the most common infecting organism? Right here. So Staph aureus. That's going to be an easy answer on the exam. So make sure you answer that one when I ask what's the most common infective organism. That's more of a lecture thing. We can have some other sources: E. coli, Haemophilus influenzae, Klebsiella, and Streptococcus B can also cause these, but again, 90% of infections are from Staph aureus, or specifically the acute suppurative one. So I didn't say this earlier, but suppurative is a pus-forming organism. Clinically, these are often younger individuals, but of course, infection can occur in any age range, so you may see in older ones as well. Males are a little bit more common. I don't know how old this stat is. That might be changing somewhat. But generally, it was the male kids would go out and play, and that's where that stat comes from. When they're young, they tend to have more systemic type of symptoms. Older individuals that have infection can have a much more indolent or not as severe reaction. So it can be harder to diagnose older individuals because they might just, have a little bit of pain, maybe a little bit of swelling, and they're like, it'll get better. Young individual, though, because the immune system's not as well formed, they tend to have a much stronger reaction to it. And then early diagnosis is essential because of how much destruction can occur in these infected areas. It can be difficult as well, especially if you're using X-ray only. So if we see some changes more clinically, we can have erythema, so redness, swelling, edema, all this type of stuff. So these are all kind of the systemic infection symptoms, or systemic symptoms in general, not necessarily infection only. Obviously, if you're looking at these, clinical pictures here, you can most likely guess that there's some sort of infection in that. This one looks like a nice, perfect human bite. So someone, maybe a zombie, decided to try to take a chunk out of them, and they found out they were resistant to the organism or something, whatever. This one here, this upper hands, that likely is some sort of infection of the deeper bone, as well as maybe the joints inside. So a septic/osteomyelitis type of case. And we can see that nice thick scab there and some swelling and some redness. If you look closely, you can also see it kind of goes down the arm all the way down here. So it might be a little bit further. Maybe this was the initial focus, and then it started spreading either through lymphatics or bloodstream to more proximal areas. When we're looking at early signs, especially in younger individuals, if you look at this x-ray, there's really not that much going on. The biggest finding here is there's a little bit of swelling seen on the lateral aspect of the wrist. So here's the radius here, so this is lateral, right? And if we look at the fat planes on the ulnar side, we can see that they're pretty clear. So this is more subcutaneous fat tissue. And then we're getting into more of the muscular slash joint, right? So in this kind of demarcation right here, it has a very nice separation. We can clearly see the difference between one and another. When we look at the other side, you can kind of catch some of this wispiness, and it almost looks like it's extending a little bit. So it's kind of getting maybe some feelers, if you want to think of it in that sense. But the fat plane, or the muscle fat plane, is dirty. It has a much more wispy appearance to it. And really, that's the only changes we see on this image. Let me take that back. There's a couple other things, but that's the biggest change we see on this image. So this area right in here, we're losing that nice fascial plane. There is a little bit of change in the metaphysis here. So kind of this region, we're starting to have some osteolytic change there, but that's not as easy to call because this is still a younger individual. This is a very young person. Um, it does look abnormal, and it is something you should follow up on, as they did in this case, where they went to an MRI, and now we can see how much more prevalent that change is. So this is a some sort of fat suppressed, so they've reduced the fat signal, and it's more T2 or stir. So it's much better at showing inflammatory change in water densities. So all the white stuff you see here, that's all water density and or inflammation. Inflammation in this case because it's infection. So we can see that infectious change causing the swelling. We can see where it's also not just in that kind of subcutaneous region, but also in the deeper muscular tissue going down, and then in the bone as well. So we have all this change between the two, radius and ulna as well. We have all this change seen throughout the metaphysis into the diaphyseal region. A note on the ulna on this side, this is the growth plate right here. So the growth plate does have some more change, some more T2 signal, but that's a normal expected type of appearance for that. We can see the epiphyses as well, which we don't see here because they're cartilage. So it's loosened on the X-ray, but visible on the MRI. Okay, so early signs, again, soft tissue swelling. That was that biggest thing. We do have a little bit of that osteolysis, that bone destruction. We do not see very much periosteum in this, periosteal reaction in this patient. A big note for X-rays is when you're looking at infection or occult fractures, these numbers right here are kind of a latent period. So you don't expect to see changes until 7 to 10 days, about a week to a week and a half in the extremities, or in the spine, about 3 weeks. So if you are considering some sort of infection as a cause of patient's pain and symptomatology, X-ray is not a good tool to use because it takes so long to diagnose it. And again, early diagnosis is very important. So MRI, as we see in this younger individual, is probably the best one, though you could also use an ultrasound for more superficial changes like that X-ray or this patient here. Potentially a CT, though I wouldn't want to CT a young kid. MRI is going to be a much better modality to use. So again, if you're considering infection as a cause, MRI, with and without contrast, is going to be our main tool used, or a better tool used. All right, next individual. In the lateral aspect of the calf slash ankle, we can see there is a lot of swelling here. I mean, think about your own, fibular head or lateral, excuse me, not fibular head, that's a proximal, lateral malleolus. There's not very much tissue between the lateral malleolus and the skin surface. This patient has about 2 centimeters worth. So that is a lot of swelling, and we can see that tracks up the side of the leg. Again, we're kind of having that poor demarcation between the fascial planes of the subcutaneous tissue here and then the muscular tissue. So there's a lot of swelling in this region. If we look to the deeper tissues, the bones, we can see an area in the cortex where it's not as well, not ossified, but there's more destruction there compared to the more proximal regions. Internally, we have some more permeative osteolysis kind of in that region. Additionally, when we look in the posterior aspect of the ankle, we can see Kager's fat pad, so Kager's right in here, has become compressed by this swelling. And there's a little bit of swelling in that anterior aspect too. So this patient has mostly soft tissue swelling with a little bit of permeative osteolysis. There's open growth plates. So our top three differentials in this are osteomyelitis, osteosarcoma, and Ewing sarcoma. Because there's so much swelling in this and it's not really a soft tissue mass, I like infection as a cause much more than, say, the tumoral causes. Tumors tend to cause more mass, soft tissue mass. So we see extension of that tumoral process from the bone into the soft tissues. Here, this is more the appearance of swelling and not something growing out of the bone. Not always an easy call to make, though, so obviously I would still keep those three differentials, osteomyelitis, osteosarcoma, and Ewing sarcoma. In this proximal femoral metaphyseal region, we can see an area that sort of looks almost like a geographic osteolysis, maybe in this portion only, but it does still kind of have these almost wings to it, and we have some endosteal scalloping here on the A to P view. On the frog leg view, we can see where it's much less defined though, so it has a longer zone of transition. So we're more of a permeative slash moth-eaten osteolysis. It's an older individual here. Without an age, I would start going through more older things, so metastatic disease, potentially plasmacytoma or multiple myeloma. Lymphoma is also a consideration, but you still may consider osteomyelitis as a cause. In fact, if we look closely, where's my zoom in tool? If we look closely along the lateral aspect of this femur, we can see a little bit of periosteal reaction here too. So there's a single layer lamination, periosteal reaction. That doesn't really help our diagnosis, but it is something else to note and consider a little bit on the anterolateral aspect here as well. Follow up, again, you always want to follow up with some advanced imaging to better visualize these destructive changes. So now we have a STIR image here. STIR is like a better T2, so you can think of it as T2 plus plus. So we lose all that fat signal, we have no subcutaneous fat. So really anything that's bright is going to be more water density or inflammatory change. So in the pelvic bowl, this is a female, I believe. Yes, this is a female. Nope, that's a male. Yeah, there's some soft tissue structures in this region. So these are more going to be like bladder structures and kind of cutting into part of that. But that's okay. Pelvic bowl, whatever. We don't really care about that. The main changes we're looking at here are the proximal femur. So there's that inflammatory focus, the infections in that area, and we can see where there's a lot of swelling. In fact, there's some muscular change, wispiness and inflammatory change in that muscle as well. So the infection is either wholly in the bone or it's in the muscle as well, or possibly it's in the bone with some inflammatory change due to just the irritating nature of it. So yeah, still going to be our kind of destructive diagnoses. Because there's no real soft tissue mass growing out of the bone and we have more just inflammation, kind of like that swelling, I do like osteomyelitis as a better diagnosis based on this MRI that we're looking at it. Pre-contrast and post-contrast, we can see where there's more loss of the normal marrow signal. So marrow signal should be closer to what's up here. We don't really have too much of it though, and we're kind of cutting into the more cortical region, so we don't see a great analog for marrow. But it should be brighter. It should be closer to subcutaneous fat, which in this case we can clearly see it's not. Post-contrast, they've suppressed the fat in the region we're viewing, which we can determined by looking at this subcutaneous tissue here, and we can see where there's some post-contrast enhancement when comparing the two images. The central portion we don't see any contrast in. The reason for that is this part's necrosed. So this is more of a dead necrotic tissue where we have more of that inflammatory change and viable or active bacteria seen in the peripheral aspects of that region. If this goes on and either gets treated, but the bug doesn't completely go away, or it doesn't get treated, this could potentially turn into a Brodie's abscess. So these are more of like the acute to subacute stages where we're starting to get some necrosis and the body's doing its best to kind of separate it, or will be doing its best to separate it from the rest of the healthy tissue. Okay. So those are more of the early findings. Again, MRI is going to be a much better modality to use. Some of the later changes we see are these four terms, and these four terms make very, very easy lecture test questions. So look for kind of these type of words, not necessarily this exact statement, but something that relates the same information. So there's a sequestrum, a sequestered or separated fragment or portion. There's an involucrum, something that is trying to involute or kind of separate that sequestered portion. There's a cloaca, much like every other cloaca you've heard of in biology. It is some opening. And a sinus tract. Sinus tract is like a cloaca plus. So you kind of need an opening of the diseased tissues and then a tract, hole or tube or something that transmits that diseased tissue into either a hollow organ or out of the body. And that's the sinus tract. So the sequestrum is the necrotic infested portion that gets kind of separated. And we can see this calcify. The involucrum is generally periosteal formation around that sequestered or necrotic area. If it's incomplete, that involucrum, we can get a cloaca. And if there is a opening or tract from that diseased portion into the hollow organ, so if it's in like the spine, say the stomach, or if it's in the leg or arm, if it goes out to the open world outside the skin, that would be a sinus tract. So this is kind of the classic picture. This is an ACR file, I believe, and we do have this in our path file. So this is like the classic picture of osteomyelitis, more of the later stages of it. So it's kind of going towards a chronic form, where we can see not all four of those, but three of them. So this kind of cylindrical portion we're seeing from here to here, so this area right in here, this is all the sequestrum. It's that sequestered or attempting to be sequestered necrotic portion of bone. It has calcified, so we can see where it's more dense. It kind of looks like it's just the medullary cavity continuing on where we lose the cortex. Not quite the case, but it's that calcified, dead necrotic portion. It is the sequestrum. We have a nice solid periosteal reaction coming up and around, kind of 360 degrees around the bone, both proximally and distally. That is all the involucrum. So that's not a great arrow. That so all involucrum in these areas. Again, we can see it in the lateral view as well. It's that solid periosteal reaction kind of trying to surround and separate that sequestrum or the sequestered necrotic portion away from the healthy tissues. And then we have this kind of opening here where the area of the dead bone can go out into the immediately adjacent tissues. This would be a cloaca. This is an opening. And if you think of this as kind of like the bone itself is 360 degrees. So all around it here, it's open out. So that's that cloaca. So if you think of like a donut, a negative donut, so the hole around it, that's all that cloaca portion. So let me just erase this real quick. So again, we have the sequestrum in here, the dead necrotic portion. The involucrum is the periosteal reaction. And the area where this kind of disease can come out is the cloaca, or the opening of the infected portion into the adjacent soft tissues. We do not see a sinus tract in this individual because it's X-ray, and X-ray is really not a great modality to evaluate or see sinus tracts. MRI could, and I'll show you some examples of that as we go on. Next, going to spondylodiscitis. So this is specifically infection of the spine, the vertebrae, and intervertebral discs. Again, Staph aureus, most common infective organism. Very easy test question to write. Star, circle, highlight, whatever you want to do with this. I mentioned the latent period, 3 weeks. There's a slightly different pattern when comparing adults to children in the initial infective area. So children have much more vascularity going to the discs versus adults, where that vascularity, the arterial supply, goes more into the superior anterior corner. And then from that corner, we then can get some destruction of the discs as a kind of direct extension. Just a reminder, it's a hematogenous spread, so that's why it tends to, for children, infect the disc first, and the anterior portion of the bodies or end plates in adults, because this is just where the arterial supply enters that area. So here's more of the adult form, and this is in Yoakum and Rowe, so I highly recommend you go quickly look through that, because it'll pretty much tell you the same stuff I'm talking about, but there is a nice capstone summary that you can look at to help just kind of put all this stuff together. So arterial supply comes into these regions, and that kind of spreads and branches out. So that's where we tend to see this infection in more of the supero-anterior portion of the vertebral body / end plate. From there, it tends to spread into the disc, and then we can get kind of infectious change on either side, as well as, or potentially instead of, change underneath the anterior longitudinal ligament, or just outside the body's spinal regions in general. So the big things with that kind of changes we expect to see is often we'll have anterior body destruction, we'll have end plate loss, the discs will be destroyed, and we might have an abscess. So these are your main findings that you want to look for on imaging, for X-ray specifically. Well, not specifically, but X-ray findings that we expect to see for spondylodiscitis. And remember, if you see this infective change in the spine, you got to call it spondylodiscitis. If you write infection or osteomyelitis, that is incorrect. All right, so let's look at that. Looking at this individual, we have a lateral cervical spine here, and kind of looking at the vertebral bodies and everything, they look okay in general. There's not a really great change that we can see in any of these areas. If we're doing our 5 cervical lines, we can see the spinal laminar junction looks okay. The posterior body line looks, I guess spinous tip, I should talk about that one first. That one looks okay. Spinal laminar junction looks okay. Posterior body or George's line looks okay. ADI / anterior body line looks in well alignment. When we look at the prevertebral soft tissues, though, this is the level of C2, right? C2, how big should this be? If we remember our rules of 6s and 2s, at C2 it should be 6 millimeters. So 6 mm. Wow, it's hard to write. Yeah, that's supposed to be millimeters. Just imagine 6 millimeters, and then at C6, 2, 3, 4, 5, 6. At C6, that's where it gets to be 22. So down here, it's okay. That's probably right at about the upper limit of normal, if not a little bit bigger. I have to get a ruler out to properly measure it. But this right here is way bigger than 6 millimeters. So from C1 all the way to C5, we have some prevertebral soft tissue swelling. Now that should clue you into something's going on. So if we look a little deeper in these areas, C5 looks okay. 2, 3, 4. Make sure I'm saying the right number. Yep. So C5 looks okay. C4 looks okay. C3, if we look at the anterior aspect right in here, we kind of lose that cortex. We're losing some of the superior end plate as well. So there's some osteolytic change seen in those areas. So this is more of those earlier findings. We have that anterior superior body destruction of C3. So that's going to be our early changes, as well as the large amount of prevertebral soft tissue swelling. So that could be a paraspinal abscess, as I mentioned that last one. Here's a more further along patient. So on the x-ray, we can see at the level of C3-4, we have loss of the end plate, anterior body destruction, loss of disc height. This is our classic changes of spondylodiscitis. So this is a good example that you can look at and you can say, well, we've lost end plate and we've lost disc. So we have an aggressive destruction. This is likely an older individual. So generally when we see aggressive destruction in an older individual, we think more cancerous causes, right? So that's the metastatic disease, multiple myeloma, lymphoma differential. What takes us more towards infection in this case is the fact that it's involving the disc, the intervertebral disc. Tumors do not like to go where there's no vascularity or blood. The IVD does not really have vascularity. It relies more on the vertebral bodies and the related tissues around it for more of that diffusion for nutrition. So tumors do not often infect the disc until very late in the disease. Infection, on the other hand, doesn't really care. Infection just likes to destroy. So the infection or the disc changes really bring us much more towards infection versus a tumoral cause. So this is a pretty easy diagnosis of spondylodiscitis. So it's affecting the spine, spondylo, disc, and it's inflammatory or infectious, itis. So they got the itis here, right? So spondylodiscitis at L3-4. We can see some of those changes here. They're not as easy to see on the frontal view. The biggest change we see is the loss of disc space in that region. The follow-up MRI, this is a T1 post-contrast. So the marrow is dark because it's fat suppressed as well. I guess I should write that. So T1 fat suppressed post-contrast. And the area where we can see this kind of increased signal is the infectious change. So this kind of region in here. We have a little bit of paraspinal or epidural abscess as well, where it's kind of spreading in the posterior tissues, kind of going beyond the vertebral bodies. And then clearly that disc plane right there is not normal compared to the others because there's that destructive change. Here's another example. This one's just a really, really bad, really widespread change. And this one, I mean, you could definitely think tumors with this. This is just a lot of destruction. The discs themselves, you can't really see where the vertebral body is. Like I know it's somewhere in here because I can kind of see some stuff, but I can't tell exactly if those discs are involved. So when looking at this one I'm going to go with a much wider differential. I would still have infection on there, but I would likely be considering some sort of tumors as well. And in fact, when we look at the L4 above it, we can kind of see that this looks more sclerotic. So maybe this is like a really, really bad lymphoma. So my differential's wide on this one. Metastatic disease, multiple myeloma. Never mind, take multiple myeloma off because there's blastic change. So metastatic disease, lymphoma, and infection or spondylodiscitis. The MRI we see here, this is a T1 image. So the MRI here, we can see that there's widespread change, and now we can tell that the discs are a little bit more involved, And we're starting to see some of that destruction in that anterior aspect of the L4 body above it. So this does take us a little bit more, or it's more evidence towards a spondylodiscitis, especially since we don't see kind of spots elsewhere, and it's really only that local area or that local segment, which is much more infectious type change. Here's another one. So we have loss of the anterosuperior end plate / corner, as well as some destruction of the end plates, the superior and inferior end plate, loss of disc height. So this is a classic example of a spondylodiscitis. And we can see in the STIR image here and the T1 post-contrast, T1 fat suppressed, not fat suppressed, never mind. T1 just post-contrast, because we still have some of that bright tissues, where we can have that inflammatory change on the STIR. So again, a better T2. We lost disc height. We see destruction of the disc. We can see where it's spreading into the tissues around it as well. So prevertebral abscess. And in the post-contrast, we can see where there's active infection, as well as just that kind of contrast enhancement of the bodies and the abscess anterior. There's likely some inflammatory change and or infection in the posterior aspects too. So this person potentially could have had some surgery, or maybe they get some sort of implantation. I don't know, laid down on the ground on a rusty nail or something. Why they would do that, I couldn't tell you, but I'm just reaching here. Again, hematogenic spread is the most common source that we would expect this. So it could have been from elsewhere in the body, although the fact that these kind of areas, the vertebrae as well as the paraspinal soft tissues, posterior paraspinal soft tissues, makes me think it's a little bit more likely that there's some sort of direct extension from those areas. Regardless, spondylodiscitis, pretty easy one. So again, big things for spondylodiscitis, what we're looking for is body destruction, end plate destruction, and disc loss. So if you see those in combination, the end plates and disc and or body being destroyed, that is a pretty much slam dunk for a spondylodiscitis. All right. Treatment, again, if you find this early, it's going to be a much better prognosis. Often there'll be some sort of IV antibiotics. So this is going to be the standard early treatment. And then if it's more late that they found this, there might be some sort of orthotic needed. So they could potentially have to have surgical change, joint replacements, and or going in and cutting it out and removing the infected tissue as a treatment. Yeah. All right. Next, Brody's abscess. This is going to be on our phlegnomachic. All right. So this is the I in phlegnomachic. So dot 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 I C. So Brody's abscess is the I. So it's infection, but specifically it is the Brody's abscess. So it is more of a subacute to a chronic suppurative infection. Staph aureus. Hey, look, another easy, most common, right? Staph aureus. So what happens here is the infection occurs, and then the body starts to wall it off, and eventually it is just kind of removed from the rest of the tissues. It creates this general geographic osteolytic change with some amount of sclerosis around it. Again, the body's trying to wall it off, so it does that by, shoring up the walls, making more dense bone around it. With these, the actual abscess might become sterile. So the body might have completely removed it, but it still can cause issues because, well, it's this abnormal abscess inside the tissues. So this is common, or a common history is night pain relieved by aspirin in kids. Hey, where have we heard that before, right? That is the classic osteoid osteoma history. So this is a potential differential for an osteoid osteoma, both clinically and imaging wise. based on size. Once it gets bigger, so osteoid osteoma, if you remember, it's less than 1 centimeter or 1 centimeter or less is the nidus. Brody's abscess and osteoblastoma can get bigger. So this one is less than 1 centimeter. This one is greater than 1 centimeter. So that's where these differentials come from. And then because there is an amount of reactive sclerosis around it, a fatigue fracture may also be a consideration. So fatigue fracture is the bone is subjected to normal forces, just a lot of them, and the body cannot properly heal the damage quick enough. So we start to get these microfractures, and as the body is trying to heal it, we get this kind of sclerotic change. So if we can't see a nidus, a fatigue fracture might be or could be a proper differential for Brody's abscess. So clinically, as well as imaging, these are all kind of differentials for each other. So Brody's abscess imaging features, most commonly seen in the metaphysis of tubular bones. So the distal tibial metaphysis is the most common area. It's a geographic radiolucency, has sharp margins, so a short zone of transition, and commonly has some sclerosis around it. So the O and the I can look like this. These are kind of similar ones, and they'll often be on differentials for each other. With the amount of sclerosis anyway. If there is no sclerosis, the I isn't really a great differential. Here we look at this younger individual. We have open growth plates. We can see this geographic osteolysis. There is an amount of reactive sclerosis around it. That nidus is clearly greater than 1 centimeter. So we start going down our differentials. The best ones for this are going to be a Brody's abscess or an osteoblastoma. Because it's eccentric, you may also consider this as possibility an aneurysmal bone cyst. Because it's eccentric, it's bubbly lytic. This could be more early changes of an aneurysmal bone cyst. But I really like Brody's abscess and also, to a lesser extent, osteoid osteoma for this type of appearance. On the T2 MRI, so T2/STIR, what we're looking at here again, that kind of area of increased density or increased signal, consistent with more inflammatory change inside something that is walled off. So we can see a nice kind of, or a thin linear black line around it. And that's kind of that fibrous tissue that is created by the body to kind of help wall it off. And then it starts laying down that sclerosis around it. A couple other examples. So this one here, this one's just kind of that reactive sclerosis. So this is where you start going down the wider differential of fatigue fracture, Brody's abscess, osteoid osteoma. There's really no classic examples of any of it, or something that differentiates any of those here. We have that reactive sclerosis and solid periosteal reaction. Advanced imaging would need to be needed or would be used to narrow it down and or a biopsy. These latter two images, or the right side images, we have more of that kind of geographic lytic lucency with variable amounts of sclerosis around it. These are more classic Brody's abscesses. Brody's abscesses also can involve the growth plate, which speaks more towards an infectious change versus a neoplastic change. Because again, neoplasia doesn't like areas that don't have a lot of vascularity to them, and the growth plate's cartilage, which is non-vascularized. So tumors don't really like to extend across it so much versus an infection, where infection is much more common to have that involvement and extension through the growth plate. Okay, next, septic arthritis. So this is going to be infection of a joint. Commonly, this will be a single joint, but that is not a rule. It can affect multiple joints depending on the virulent nature of the pathogen or bug, as well as the compromise or the immune state of the patient. Hey, Staph aureus, most common organism. Easy test question. Still hematogenous spread, could be direct implantation. Clinical features, you get somewhat more of a joint type findings. You can get limps and or swelling at that joint, but still classic infective symptoms: chills, fever, pain, redness, increased white blood cell count, as well as inflammatory markers. Most common location is going to be the knee, and then another common location is the hand, human bite. So I mentioned before, getting into a bar fight and punching someone in the face and them cutting your metacarpophalangeal joints, MCP joints on their knuckles. Well, that's kind of how that happens. So often we'll have some sort of effusion. We'll see distortion of the fascial planes. We'll lose that joint space, and we'll lose the subchondral white line. So this is the articular surface of the bone, where we start to lose that normal kind of cortex or articular surface. Moth-eaten or permeative bone destruction, so we start to see that aggressive osteolytic change. And then late stage, this can actually result in bony ankylosis. So the body just starts healing things. If you lose both edges of the joint and you get just bone on bone, well, the body's going to heal that as one single bone. So that's what we can see in that, causing that bony ankylosis. All right, looking at this hip, frontal hip, A to P view, we've lost that kind of gluteal fat stripe or lateral capsular fat or hip capsule fat stripe. The medial one's still there, though it's starting to be a little bit more convex. The big changes here, though, are when we look at the hip joint themselves. We have a nice, rounded femoral head. That looks fairly well maintained, but femoral head's supposed to articulate with something, right? It's supposed to articulate with the acetabulum. Where's the acetabulum? There is no acetabulum in this case, or there's no joint space in this case. We've lost Kohler's teardrop. So we're losing that superior, the roof of the acetabulum. Like, where is it? We're losing the medial aspect of the acetabulum. So that's that loss of the subchondral white line, as well as loss of the joint space. Classic septic arthritis changes. Here's a good example of septic arthritis in a kid. So we've got some open growth plates, and you can see the date here, January 1st, 1958. And they're measuring the distance between the medial wall, or the medial femoroacetabular joint space, side to side. We can see in the patient's right, we have a wider joint space. This is what's called a positive Waldenstrom sign. Is there a typing thing? There is not. Okay, let's do this. Waldenstrom sign. So Waldenstrom sign, what it is it is in a immature hip, Waldenstrom, in an immature hip greater than 2, and it's got the umlaut, greater than 11 millimeters absolute value or 2 millimeters difference side to side. So there is a positive Waldenstrom sign on the right because that hip joint is enlarged. And this is a non-specific finding or a non-specific sign for hip joint effusion. So I can't tell what's causing this effusion. This kid could have just fallen on their hip and it hurts now. But infection is one of the potential causes. So positive Waldenstrom sign. 26 days later, well, now we're starting to see more of those infectious changes. So in 26 days to lose that joint space, that is an aggressive change. And that is a that's a lot of evidence towards an infection, because tumors aren't going to affect the joint themselves or the joint only, versus an infection where we can see kind of that joint change by the chondrolytic enzymes that can be created by various infective organisms. We're also starting to lose some of that nice subchondral white line, so it doesn't look as well visualized here anymore. We're getting some osteolytic destruction, so we've got kind of some circles Um, there's some areas of destruction in here. So we've lost that subchondral white line up there. And again, joint space is destroyed. So that was 26 days. Whether this patient was actually getting treated or not, maybe this bug was resistant, or maybe they couldn't afford it. So this is why we're seeing these changes. And then unfortunately, it didn't get treated. So about 2 months after that previous image, we can see where the acetabulum is now just gone. It is destroyed. We've lost the lateral aspect. We're now getting more necrotic changes in that femoral head. We're losing some of that, normal bone density, and now it's spreading to other areas. So these arrows pointing to this region are showing I don't know why it does that, are showing a new infected focus. So the arrows are pointing at a sequestrum. We don't really have an involucrum or cloaca that is well visualized here, but we've got septic arthritis plus osteomyelitis. And very late stage changes. I don't know if this is the same patient or a similar case. Very late stage changes. Now we have that ankylosis. So we have that fusion of bone from the femur to the acetabulum, or to the ilium, and that is not a joint anymore. That is just one bone. Okay, septic arthritis. Again, one of the common causes are fist fights, um, or human bites, and fist fights as a etiology of that. Commonly be in the metacarpal phalangeal joints. So you go for the crazy roundhouse haymaker, and you punch the guy right in the mouth. And as you do that, well, his teeth cut your hand. And that can cause all these changes, and you can get more widespread destruction. One of the kind of stars that boards likes to ask is intravenous drug users. Now, in a person who uses intravenous drugs, they have a higher incidence or a higher susceptibility to Pseudomonas infection, and that hits the S joints, so the spine, the sacroiliac joint, the symphysis pubis, the sternoclavicular joint, and the sacromioclavicular joint. So obviously there's no S on that joint, but it only fits if you kind of give it the S in front of it, right? Because then it's not an S joint. But the S joints, big distinction here. If I ask what is the most common infective organism in an IV drug user, it is still Staph aureus, because that is the most common overall. If I ask what in an IV drug user, what is a organism of higher incidence, Pseudomonas would be the correct answer. So just make sure you read the question. Likely, if you see something about IV drug users, it's going to ask for Pseudomonas as an answer, but I cannot predict all the questions on boards. So just make sure it's not asking for the most common infective organism, which is still Staph aureus. All right, 9-year-old male presents with increasing low back pain, 3 weeks duration, insidious onset. This image here, doesn't show very much. We have a lot of bowel gas. I don't see the kind of margins here, so this is an area I would want to further image. We do have some bowel gas crossing that, but it should still be visible. So the right SI joint / ilium is the area I'm mainly concerned with in this individual. I want to get kind of a spot shot there. Oops, wrong direction. With that spot shot, we can now see that there's more change, and it's not just that bowel gas that's doing it. So again, if we look at this margin here, well, I lose that nice cortex at this region. We have some permeative osteolysis through the ilium. The sacroiliac joint, it's a kid, so there is some variability, but I wouldn't expect to see kind of this loss of that region, as well as, kind of this wispy change in through the sacral side. So all of this is making me think septic arthritis of the SI joint. Follow up CT in this panda bear view. Yeah, looks like a panda. So eyes, nose, kind of cute. There's some ears. This ear is a little bit ragged though. So this ear is ragged because of that infection. So we can see the normal left side. We can see where there's that nice subchondral bone or articular bone versus the right where we've lost that. So it should be in this region and it is not. And then we have some amount of sclerosis around it as the body's kind of attempt at healing and walling off that area. So that is a case of septic arthritis. When we look at a unilateral sacroiliitis, so this is kind of going into next semester with Dr. Peralt. You'll talk about these latter three diseases. The one that really is our purview for bone path 1 is infection. So unilateral sacroiliitis. These are the things that can cause it: rheumatoid, psoriatic, and reactive as more inflammatory diseases. But infection is got to be on your list for a unilateral sacroiliitis because infection tends to be more single joint, and these latter three are often more multiple joints. And you'll talk more about those next semester. All right. With chronic infection, or excuse me, with infection, if it is not treated properly, or it is a organism that is resistant, you can get more chronic changes. So radiographic findings, the big thing with chronic osteomyelitis is you start to see some more bony tissue. So sclerosis, periosteal new bone, so that solid periosteal reaction, which thickens the cortex. And then you can still have signs of active osteomyelitis. So there can be both sclerotic change as well as lytic change, which is kind of a combo plotter of both acute and chronic osteomyelitis. So chronic osteomyelitis, we do have a differential for this, and one of these we've talked about, and another one I'll get to in the next Panopto. But Paget's disease and melorhiastosis, both of these are sclerosing bone conditions. So chronic osteomyelitis has sclerosis, Paget's disease has sclerosis, melorhiastosis has sclerosis. With chronic changes of osteomyelitis or infection, we can get malignant degeneration. So of the kind of area infected itself, we can see fibrosarcomas develop. And then of the sinus tract, we can have a Marjolin's ulcer or squamous cell carcinoma. So that's of the sinus tract. Often of the sinus tract. I guess it's not always. Could be of like a cloaca or potentially subcutaneous involvement. But Marjolin's ulcer or a squamous cell carcinoma of that kind of epithelial lining in that tract. So younger individual, we have this sclerosis and we have areas of osteolysis as well. So this is a infection that was either not treated or not treated to the full extent. We're getting more of that periosteal reaction, cortical thickening, kind of wavy new bone production. This is a pretty good example or a pretty classic example of a only chronic osteomyelitis as a diagnosis. Melorhiastosis doesn't tend to have internal destruction as well, which we're seeing here with this osteolysis. And Paget's disease is an older condition. So this is really just a chronic osteomyelitis as a diagnosis. Another example, here's more of an older individual. So this one does have that sclerotic change. And I don't know how well you can see it here, but there's a couple arrows in this region pointing to kind of this area. So this whole area right here should have bone still. Again, as I mentioned, chronic osteomyelitis, we expect to see thickened cortex and more bone. Well, this is likely some amount of squamous cell carcinoma of a sinus tract or area in between. So this would be a Marjolin's ulcer. So thickened cortex, sclerosis, superimposed osteolytic change. So chronic slash maybe some active areas of osteomyelitis, as well as a Marjolins ulcer or squamous cell carcinoma. Sclerosis, this is more of a sequestrum and an involucrum. We have a little bit of a cloaca. So sequestrum, involucrum, cloaca, chronic, subacute-ish chronic. So the rest of the bone's more sclerotic. Younger individual, open growth plates, chronic osteomyelitis. Another example of that skin ulceration and or Marjolins ulcer. So I would consider this as a Marjolins ulcer here. So in this patient with this sclerotic change, periosteal reaction, and this kind of scalloped out area in the skin, bad changes, squamous cell carcinoma or Marjolins ulcer. All right. Another example of a cloaca. So we have this sclerotic change where we can kind of see a hole coming towards us now in this lateral view. So this hole here is likely this kind of change right in here. So we're getting this kind of area going out to the surface of the bone, and that's that cloaca. So here we see it on the MRI. There it is. There's the cloaca. In fact, it looks like it's going out to the skin tissues or to the surface tissues. So this would be a sinus tract. Oop, running off the image there. Sinus tract in that cloaca or extending from that cloaca. Apologize to any that are squeamish. It's kind of gross. But diabetes is diabetics have a high risk of infection, especially in distal tissues. So feet, ankles, those are areas we really are concerned for diabetic infection, osteomyelitis, or potentially neuropathic arthropathy. This is something you'll talk about next semester. So here we have that ulceration, likely is infecting the tissues deeper as well. So in this patient here, we can see that they've had a resection of their fourth metatarsal, likely because they had some issues with it in the past and they had to take it out. And now those changes are continuing on, or additional changes are continuing on in the third metatarsal. So we're getting more sclerosis, periosteal reaction, that joint space doesn't look so great. So a combination of both septic arthritis as well as infection in the bone. If you see on an exam, if you see a foot involved as a septic arthritis and or chronic osteomyelitis, and I ask the question, what is a possible etiology or underlying condition? Diabetes is a good answer. Hint, hint. All right, more examples, diabetes and infection. So initial presentation, foot pain. If we look at the third MCP, metacarpophalangeal joint, we can see that we're losing some of that normal articular bone. So subchondral white line is starting to be destroyed. 5 days later, even more change. So destructive osteolysis as well as loss of that subchondral white line. And then 2 weeks later, well, that joint is just destroyed, and now that infection is moving more proximally. So diabetes commonly involves the foot. Here we have a large amount of swelling around an ankle. We've destroyed Kayer's fat pad. We've lost most of the talus. So we have kind of like the talonavicular joint. This region's still alive, still going. We have septic arthritis involving the subtalar joint. So where's the subchondral white line there? Where's the rest of the talus? All that swelling, septic arthritis of the ankle, and likely there's some change down here as well. So fifth metatarsal styloid process gone, cuboid fragmented. So likely a diabetic with a combination of septic arthritis, multiple areas, and or neuropathic arthropathy. The neuropathic arthropathy part you'll talk about with Dr. Peralt next semester. Again, I apologize for those that are squeamish, kind of gross. Additionally, what you can see with osteomyelitis of any cause and cellulitis, but more commonly in diabetics, is gangrene. So if we look at the subcutaneous tissues and then in the kind of tissues on the axilla here, we can see these lucent streaks throughout them. So there's kind of this lucent streaks in here and throughout there. This is all subcutaneous emphysema, consistent with a gas gangrene. All right, next, moving on to a non-suppurative infection. So tuberculosis and syphilis. I'm not going to ask you questions on syphilis because it's not a common cause these days of infection. Again, that's later stage syphilis, and often syphilis is treated before it gets that bad. Tuberculosis, though, is seeing a resurgence. With all the immunocompromised individuals, cancerous causes, and various other immunocompromising conditions, we're seeing more tuberculosis. Commonly, TB infection is not a United States. It's not commonly seen in the States, but we do still have it here. And again, with AIDS and immunocompromised individuals, we're seeing more of this occur in the States. So it is caused by inhalation of Mycobacterium tuberculosis, or the TB bug, and it often affects the lungs first. So primarily we see it in the lungs. It doesn't have to be in the lungs initially, but that's the common area because we breathe in those spores and the tuberculosis organism. The initial stages looks like a pneumonia, which we'll talk all about in 6th semester, so don't worry so much about that. Then it causes this granulomatous change. It is a type of granulomatous infection. And then it may never cause issues again. Patient can have a granuloma in their lungs that never reactivates and just kind of sits there, and we don't care about it then. It may reactivate, though, often in immunocompromised individuals, and then we can start seeing more changes in the lungs as well as spread to other organs. So here's an example of tuberculosis in a patient's lungs. So lung tissue should be, lucent. We should have some of this branching patterns here. Like all this is okay. This is all blood vessels and bronchi. So it comes from the trachea and all that. Trachea as well as the pulmonary trunk. And that's okay. So all this stuff in the inferior aspect is fine. If we look in the upper portions, though, this is where our changes of TB are seen in this individual specifically. So we have a kind of walled off mass up here. This is what's called a cavitating mass. So it kind of necrosed inside and or connected to a bronchus, and now air was introduced into it. On this CT here we're looking at, so both of these are CTs, we can see that cavitating mass. So this is that thing right there. And there's some other changes of some involvement, some excess material. There's another cavitating mass on the left side, which I don't see very well. But all this kind of increased density in here and in here, that's all this. So those are kind of tuberculosis changes on the chest film here. Most common area for tuberculosis to affect in the musculoskeletal system is the spine. Again, most likely younger individual, though we can see it in older individuals too. This one, fairly non-specific changes, insidious onset pain, decreased range of motion, tenderness in those regions. We can see here in this cadaveric model or cadaveric specimen that we see, we've lost that, normal inferior body. We have destruction of the discs. We're actually starting to get some abscess out into the psoas as well. So a couple abscesses there. Okay, tuberculosis, again, most commonly in the spine, so locations. This is where we'll call it tuberculose or TB spondylodiscitis. And we've got some specific things that make us say TB spondylodiscitis versus just spondylodiscitis. Used to be called Pott's disease. Um, that's kind of fallen out of favor, though. We don't really use that term anymore. Other common areas are the hips, and then the symphysis pubis, sacroiliac joints, shoulder, and also the wrist. So this kid here, this is a young spine. They still kind of have open sutures. This specimen, we can see where there's this very sharply accentuated kyphosis. So this is what was initially found by Dr. Pott, and he found this stuff, started diagnosing this stuff, and this is what's called a gibbous deformity, or this sharply angled kyphosis. Often it's going to be in the thoracolumbar region, and symptomatology compared to suppurative spondylodiscitis is not as severe. They may have some paraplegic changes because of collapse of vertebral bodies and severance of the spinal cord. And that's termed Pott's paraplegia. Again, the Pott's thing is kind of fallen out of favor. You can just call it tuberculous paraplegia. Okay. Imaging of it, we still have that latent period that doesn't change based on the infectious organism. Early changes, we can see disc space loss. One of the more specific things for TB spondylodiscitis, though, is that anterior vertebral body destruction with subligamentous spread. And you can see this is a different color. It's bolded, it's underlined. This may or may not be a question on one of your exams where it's spread beneath the anterior longitudinal ligament. So if we look at this patient here, this is a T1 post-contrast image. So T1 post-contrast. We can see where there's some contrast enhancement in this region, and then in this region, and potentially up here as well. This is that subligamentous spread. And for whatever reason, it likes to skip levels. So we can have change in, one level, and then it skips, and then it goes to the other ones, and then it skips, it goes to the other ones. This is consistent with TB spondylodiscitis. And this subligamentous spread, or multiple motion segment involvement, is what makes me say TB is the infective organism versus a regular Staph aureus spondylodiscitis. The Staph aureus one tends to only affect one motion segment. Late changes, collapse, that gibbous deformity, and then as also we can have these kind of large abscesses. So in this still T1 post-contrast, we can see in the right psoas, right here, there's this kind of low signal with this contrast enhancement all around it. Normal psoas on the left, that abscess within that right psoas here on the right. Here's pathologic collapse. So here's a vertebral body. This is a vertebral body. This is a vertebral body. And this is a vertebral body. We've lost multiple end plates. Disc planes are relatively well preserved. And then we have some vertebra plana in a couple areas. So vertebra plana or pancake vertebrae, vertebra plana or pancake vertebrae. This one I would also call vertebra plana. So they've all lost vertebral body height. They're starting to collapse. And we have that osteolytic destruction there. Here's a large paraspinal abscess or paraspinal swelling in the thoracic region. So here we have kind of destruction of the end plates and disc with a paraspinal abscess. Classic spondylodiscitis changes in general. I wouldn't necessarily call this TB spondylodiscitis because I only see it in the one area. But when we look at this lateral view, so this is a AP thoracic, right? AP T-spine versus a lat lumbar spine. We can see that there's also some changes right here. So we're starting to see more of that kind of loss of the anterior portion. Um, this in here is probably gas, though I would still expect to see normal cortex, so there might be some more subligamentous spread. We can see this region, the cortex is not so well visualized. So we've got infectious change here, infectious change here, and questionable change here. Combining these areas with the thoracic spine, this is consistent with ATB spondylodiscitis. We can see a nice large abscess in this individual on their posterior soft tissues. It's destroyed the spinal tissues, and we have some change in this L2, 5432, L2 vertebrae. So destruction there, as well as that posterior aspect. These are not the same person, by the way. Two different cases. No, actually they're probably the same person because I don't see any posterior elements here. So this is the same as this, right, this region. So it is the same. This is a T1 image, and we're starting to lose that more normal marrow signal. So that's consistent with some inflammatory change on these anterior aspects with these areas I talked about. All right, this Pfemmister's triad is a good lecture type question. For tuberculosis, we tend to see progressive, slow joint space narrowing. We have a juxta-articular osteoporosis. That's a fancy term for saying there's osteoporotic change or loss of bone density on either side. And then we get more peripheral erosions, kind of destruction, scalloping of the articular bone on the lateral portions. So we see those changes here. So slow joint space narrowing. Joint space is relatively well preserved compared to the one next to it. We have loss of the bone density in the regions around the joint. So juxta-articular osteoporosis. And then we're losing the margins. So we have erosive change on the articular surface, the margins of them. So that's that Pfemmister's triad. Some other buzzwords you might see, especially on boards. I may ask questions about this. If I do, it's going to be lecture only. But spina ventosa is specifically tuberculous infection of the digits, so tuberculous dactylitis. Pott's puffy tumor is TB of the skull with an abscess in the scalp. And Weaver's bottom is a bursitis of the gluteal bursitis that often extends into the ischium, the ischial tuberosity. This was because weavers used to sit on wood a lot, I guess, and wood can have splinters, which would give weavers this tuberculous infection. I don't think that happens these days, at least not in the States, because most weavers don't sit on, spiky wood anymore. All right, here's an example of that tuberculous dactylitis or spina ventosa. We have infection of the digit, more so kind of up to this region. Primarily seen in this proximal phalanx with this large amount of swelling. We can see changes in both the proximal and the middle phalanges, though, of that tuberculous dactylitis. Pott's puffy tumor. We see this kind of destructive osteolysis in that frontal bone. You can see it's extending into the scalp, the subcutaneous soft tissues through this region. And then a Weaver's bottom, we have this mixed sclerotic and lytic change seen in the ischial tuberosity. So the lytic change is more acute infection, and the sclerotic change is more of that chronic or subacute or chronic change. Tuberculous infection tends to have more chronic changes associated with it by the time it's found because it's never really that severe enough to cause. I wouldn't say it's never. Shouldn't say it's never. But often it has more of that kind of slower burn as opposed to more of a acute suppurative infection, where those tend to have a much greater symptomatology. All right, random cases, I will leave these for you to go over. If you have questions on them, feel free to ask. Um, so that concludes the osteomyelitis or infectious PowerPoint. And I will be recording the Paget's disease one shortly. So talk to you. Well, I'll talk at my screen in a bit. Yeah.